surprised at the reaction that the reform package has had within the NHS, given that the whole thrust of it is about devolving power. Some of the people to whom you're devolving power to, or the idea of it, are actually not fully on board with the reforms. Are you surprised?
Well, I suppose actually I'm surprised and encouraged in different respects. I'm not surprised that we've seen from organisations whose power has lain at the centre and their influence over a top-down system, finding that rather difficult. I'm not surprised that the BMA have said they don't approve of any willing provider. They never did. They didn't when a Labour government did. Nothing new about that. I'm not surprised that the Labour Party should misrepresent what we say. I'm positively encouraged by the extent to which I think general practice across the country have acted quickly to come together. I mean, in the latter stages of last year, the BMA was saying, there's no need for any of you to do anything about this for some considerable time. And actually the response of many general practice groups across the country was to say, we want to be in there and we want to be shaping this. And today I've announced actually the third wave of general practice-led commissioning consortia as pathfinders. 40 additional groups, takes us to 177, representing 2/3 of England. So, you know, I think to say surprised, I think would be going too far. Much, I think, has been what one would expect. Change is difficult. We all know change is difficult. And there are many people who, while they embrace the principles of what we're setting out to do, find the process of change and transition hard. And, of course, it is occasionally tough, including for people working in primary care trusts and strategic health authorities. But that's why actually we've kept the pace up, because actually the sooner we're able to establish the shape of how services are going to be led in the future, I think actually people will see much more the benefits of that kind of devolved leadership.
Talking around the National Health Service, the feeling very much is that these are in the right direction generally, but it's the wrong time, because it's very hard to do this in a very austere economic situation with cutbacks and so on. And how do you respond to that?
Well, two things. Firstly, would people like to explain to me when the right time is going to be?
I suppose at a time when the NHS is growing as opposed to standing still.
Right. Well then, let me explain. The point is, we don't know when that will be. We do know that we have considerable need to change the way in which the NHS works in order to deliver greater efficiency, to improve innovation, to deliver higher quality. I actually think the things that I'm proposing, I would have proposed anyway. I mean, actually, many of those here with the Nuffield Trust here know perfectly well that 5 years ago, I would have been recommending essentially the same fundamental processes of reform and modernisation at a time when the resources would have been rising by 5% real terms per annum. We don't have that. We do have a degree of protection for the NHS relative to the rest of the public services, what I think actually is remarkable that we've been able to achieve. But actually, if we are going to deliver what amounts to something like 4% efficiency gains each year, we've got to change the way in which we work. Instrumental to this is not just a pay freeze and the cut in bureaucracy, important as those are, it's redesigning clinical services. Well, how is that going to happen? Is it going to be done by the same people working in the same organisations delivering change in the future when they didn't deliver change when the resources were coming through faster and faster? No, I'm afraid organisational development doesn't tell you that that's likely to happen. But actually the processes of modernisation we're engaged in now, because they are instrumentally about transferring leadership to the front line and giving clinical opportunities for leadership and service design, is actually likely to be instrumental to the process of delivering in a more constrained financial environment.
There was some discussion this morning about, amongst NHS managers, about how in austere times like now, there will be a kind of retrenchment. People are frightened. That puts the lid on innovation. And actually, the tried and tested centralised control is going to be the safe way forward to get us over this economic sort of trough.
Well, if people inside the NHS think a constrained financial environment inhibits innovation, then firstly, if they are right, it is the inappropriate cultural response. That is not what would happen in the private sector. In a constrained financial environment in the private sector, if your response is not to innovate, you disappear. In the NHS, if the response of people is to say, well, we're not going to innovate and we're somehow going to hope that it will all be fine on the night, it doesn't work like that. What we do need innovation, we do need to drive quality, we do need to deliver greater efficiency. I actually think there are many managers in the NHS themselves, including in primary care trusts and the like, who are perfectly well capable of delivering this kind of innovation. It's not simply the case that there are clinicians, although there are many, consultants and nurse leaders in hospitals, GPs and nurses in the community who know that they can do things better. And they have said to me for years, if they would only listen to us, we could do it better. Well, the they is now me, and I am listening to them, and I am going to let them do it better. And it will be challenging, but I think they will do it. But actually, there are many managers for whom that is true. There have been managers, particularly, I think, in many of the hospital services for some years, who have been saying to me, we could do it better if only we had some of the processes in place to enable it to happen. And one of them I'll be talking about today is about creating a payment by results system that actually does support innovation, that does support redesign of clinical services, that does take care bundles and care pathways and base tariffs around that, that does enable somebody to focus on delivering the outcomes, and if they can do it in a wholly new way, actually they can innovate because they get paid for the outcome. They're not just getting paid for the content of the procedure. So actually we can help, and actually some of the managers in some of our leading healthcare providers are some of the people who are best placed then to use those freedoms.
Thank you. Some will, many I think, are very interested in this idea that you want to reduce the political level of interference within the National Health Service by creating this mandate, and many think that's about time, long overdue. But you're not going to be in your job forever. You may embody this distributed forms of power, but there may be others who don't. And the history of Secretary of States in the National Health Service, some are more centrist than others. How can the NHS really be protected from future interference under those circumstances?
Because we're putting the Health and Social Care Bill through. Because this is about legislation. Because when you look at previous, I mean, there has been quite a lot of legislation. It's not that there hasn't been a lot of legislative action in the NHS. But if you look at each of those successive bills over the last decade or so, and there's been about 6 of them, none of them fundamentally changed the constitution of the NHS so that it is more devolved and more responsive directly to frontline needs and patient requirements. All of them left in place the fundamental proposition that the NHS is at any given moment whatever the Secretary of State thinks it ought to be. I mean, frankly, I could have proceeded in doing many of the things that are part of the modernisation process without legislation. I could have said, well, I'm going to abolish most of the strategic health authorities. I only had to keep 2. I could have abolished most of the primary care trust, because there's nothing in the legislation that would have stopped me doing so. I could have extended practice-based commissioning quite a lot without legislation. But fundamentally, precisely the issue that people raise would have remained, that at any moment that switch could have been turned off. And at any moment, an incoming Secretary of State could have said, well, I'm going to do it all differently. And there wouldn't have been any consultation. Heaven knows, you go back to 2006, I think it was, and your health, your care, your say, basically proceed with anything like the consultation that is at the heart of the way I did things. So if you remember, back in July 2005, I think it was, a proposal to rip up the whole structure of primary care trusts was just published on a Friday afternoon. I mean, we're doing things in a lot more consultative way, and through the legislation we will entrench in statute these relationships. Now, what Parliament votes for, Parliament can change, but it is an enormous step forward, I think, that there is going to be clear transparency between the political process and parliamentary processes and the NHS, so that we as a government, Parliament, is very clear about what it's mandating in terms of outcomes and resources, but the NHS is then in a position to get on with delivering those outcomes as it knows best. It's what David Cameron said back in January 2006. We are going to stop trying to tell people in the NHS how to do it. We're going to be clear about what we're aiming for, like health outcomes at least as good as any in the world. But we're going to be looking to people in the NHS to decide how they best do that.
So does that in practice mean that during the year the Secretary of State will remain silent about the National Health Service as long as it's delivering its outcomes, or as it appears to be through the mandate? Totally silent?
Yes,
no announcements made through new forms of cash?
It should not be.
This is the X million for reablement, for example. This is this or this or this. That won't happen.
It shouldn't happen like that. It should be the NHS Commissioning Board who are doing that. Okay. The Secretary of State should be responsible for the mandate. The legislation is clear about the circumstances in which there can be a change to the mandate, including, for example, if there were a general election. Beyond that, actually the Secretary of State and the Department of Health should be focused on, firstly, outcome strategies, working together between the NHS Commissioning Board, Public Health England and the Department, looking at public health and social care alongside the NHS. So yes, there will be a role for those strategies, as we've already published by way of example for relation to the cancer outcome strategy and the mental health strategy. So they will be refreshed from time to time. But outside those, the Secretary of State should be focused on doing the job of setting the mandate, and there is a process for that, leading the public health challenge, which stretches right across government and is, frankly, probably calculated to deliver the greatest overall long-term improvement in health of the nation, and obviously the continuing responsibilities in relation to social care.
And that, the silence or the leaving alone of the commissioning board also relates to monitor to the same extent.
Yes, I mean the legislation is clear about the circumstances in which the Secretary of State can intervene, but they are equally clear that these are in circumstances where there is either a clear and significant failure on the part of the organisations the Secretary of State has given responsibilities, or there is likely to be.
Thank you so much.